I have the pleasure to invite Dr. Rosa Pereira from Brazil to speak about understanding the challenge of osteoporosis and low vitamin D in lupus. We are sharing the chair with Dr. Leonor Barile, who is here. Leonor, come here, please. The times are very short for everybody.
Good morning. Go ahead.
This is for you. Well, Dr. Rosa Pereira is Associate Professor of the University of São Paulo, School of Medicine, Rheumatology Division, Chief of Bone Metabolism, and Chief of Juvenile Lupus Outpatient Clinic, Hospital das Clínicas, University of São Paulo, School of Medicine, Rheumatology Division. Rosa, please.
Okay. I would like to thank the scientific committee for the opportunity to present this relevant topic about vitamin D, osteoporosis, and lupus. In the next 30 minutes, I will talk about vitamin D, osteoporosis, fractures, and the clinical recommendation. I will start with a brief introduction of the immunomodulatory effects of vitamin D, and then I will discuss disease activity in lupus and vitamin D, susceptibility to lupus development, risk factors, prevalence, and consequences of vitamin D deficiency. Let's start with the immunomodulatory effects of vitamin D. 1,25-dihydroxyvitamin D, the active vitamin D, enhance the chemotaxia and phagocytose of macrophage and increase antimicrobial peptide cathelicidin. Also, vitamin D decreases the differentiation and maturation of dendritic cells and consequently decrease the pro-inflammatory cytokines IL-12, IL-23, IL-2, interferon gamma, IL-17, IL-21. The overall effect of vitamin D is shifting the Th1, Th17 to Th2 cell phenotype and also promote the development of Treg that are important to suppress the autoimmunity. Also, vitamin D exhibits a number of modulate action on B cells, including decrease of B cell proliferation and increase B cell apoptosis. In contrast, on lupus is quite the opposite. There is a defective of phagocytose and clearance of apoptotic bodies and immunocomplexes, and induce of maturation of dendritic cells, and also increase the pro-inflammatory cytokines, include IL-17, IL-21, and IL-23. Also, there is a dysfunction of T regulatory cells and also a hyperactivity of B cells with an increase of B cell proliferation and activation and increase IgG and autoantibody production. So, vitamin D seems to have an important role to counterbalance the immunologic alteration observed in lupus patients. In fact, in vitro studies, vitamin D active inhibit polyclonal and anti-DNA IgG production by mononuclear cells from lupus patients, and also inhibit dendritic cell maturation and the expression of interferon gene. In contrabalance, vitamin D deficiency in lupus patients is associated with high serum interferon alpha activity, high B cell activation, and immunologic abnormalities. Regarding disease activity and vitamin D level, the most of studies with a different population show an inverse relation of low vitamin D and disease activity, including the major organ involvement, renal involvement, neuropsychiatric involvement, and also skin disease, fatigue, and SLD scores. Our group demonstrated in juvenile systemic lupus patients that vitamin D deficiency occur in more than 50% of patients, and these patients present a high SLEDAI score and lower C4 levels. Relation to susceptibility to lupus development and vitamin D level, in an inception cohort study of more than 100 new onset of lupus patients, lower vitamin D was observed compared to 204 controlled population, adjusted for age, sex, season, and smoking. And also, lower vitamin D was observed in African American patients' lupus compared to Caucasian lupus patients. So the authors conclude that low vitamin D is a possible risk factor for lupus development. In another study, European American case control study, lupus patients with vitamin D deficiency lower than 20 nanograms per ml present a higher interferon alpha activity than those with higher vitamin D. And interestingly, in this control population, vitamin D deficient was more frequent in control subjects with antinuclear antibodies positives compared with the ones negative. The authors suggest that vitamin D deficiency might be a trigger for autoantibody production. In an elegant study from United Kingdom, the season variation in the birth of patients with immune disease, including lupus, there is an inverse correlation between the risk of development of this disease and vitamin D status in the third trimester of pregnancy. So, supporting this notion, the prevalence of low vitamin D is high in lupus patients, up to 96% for vitamin D insufficiency and up to 54% for vitamin D deficiency. And the vitamin D levels were lower in lupus patients than matched control in the most of the studies. There are many risk factors for low vitamin D in lupus, among them photoprotection, renal insufficiency, anti-vitamin D antibodies, overweight patients, dark skin pigmentation, and long-term use medication. Regarding long-term use medication, glucocorticoid has been associated with low vitamin D, since this drug accelerates 25-hydroxyvitamin D and 1,25-dihydroxyvitamin D, the active vitamin D, catabolism, and also reduce intestinal absorption of calcium. Interestingly, anti-malarial drugs is another drug involved in low vitamin D. This drug inhibits the conversion of 25 in active vitamin D. Antiplatelet drugs also upregulate the enzymes responsible for vitamin D metabolism, resulting in a conversion of 25-hydroxy into inactive metabolites, and also reduction the active vitamin D. Regarding immunosuppressive agents, cyclosporine and tricholism suppress vitamin D receptor and several vitamin D regulatory genes. There are also other consequences of vitamin D deficiency in lupus, including fatigue, cardiovascular system alteration, and bone metabolism compromise. In fact, low vitamin D in Caucasian lupus patients has been associated with high fatigue score, and a longitudinal follow-up of these patients for 2 years observed an improvement of vitamin D was associated with significant drop in fatigue score. So, the authors conclude that chronic vitamin D deficiency induces proximal myopathy and reduction in type 2 muscle fibers, and muscle fibers present vitamin D receptors. Regarding to cardiovascular system and low vitamin D in general population has been associated with alteration renin-angiotensin X, increased peripheral resistance to insulin, altered vascular endothelial function, and coronary arterial calcification. And importantly, in hypertensive individuals, low vitamin D was associated with all causes of mortality and including cardiovascular mortality. In lupus, low vitamin D was associated with high LDL, HDL cholesterol ratio, high triglycerides, high BMI, insulin resistance, disease activity score, and aortic stiffness. Also, as we expect, bone metabolism compromise is also another consequence of vitamin D deficiency. Our group demonstrated in juvenile systemic lupus patients with vitamin D deficiency lower spine bone mineral density and lower whole body bone mineral density compared with patients with juvenile systemic lupus with vitamin D normal. Also, in premenopausal women with vitamin D deficient compared with vitamin D insufficient, lower femoral neck BMD was observed, and a trend to better BMD gain in lupus with vitamin D higher using bone active agents. So, vitamin D deficient is an important risk factor for osteoporosis and fracture in lupus, but not forgetting traditional risk factors and disease-related risk factors. Concerning to traditional risk factor, an independent association of age, postmenopausal status, low body weight, low body mass index was observed for osteoporosis in lupus patients, and in a Hopkins lupus cohort, smoking was associated with fractures. Regarding disease-related risk factor, inflammation with an increase of oxidase LDL and TNF was associated with an increase of production of RUNC ligand and consequently a maturation and activity of osteoclast cells. Also, oxidase LDL and TNF decrease osteoblast maturation. In fact, some patients with low osteocalcina serum levels, a marker of bone formation, and an increase of CTX, a marker of bone resorption, was observed in premenopausal women with recent lupus diagnosis with no medication. Concerning disease-related risk factors, glucocorticoid treatment has been associated for bone loss, and vertebral fractures, mainly with daily dose of glucocorticoid, but even doses higher than 5 milligrams per day for more than 3 months are associated with vertebral fractures. In fact, long-term use of glucocorticoid decreases bone formation with decrease of osteoblastogenesis and increase in apoptosis of osteoblasts and of osteocytes. We have been previously demonstrated in vitro that glucocorticoid treatment drive to adipocyte instead of osteoblast cells by an increase of PPR gamma, a transcription factor for adipogenesis. In a recent review from our group, we observed in the majority of clinical studies there is a negative association of glucocorticoid and bone mineral density, and patients using glucocorticoid have 5-fold the increase of clinical fractures compared to health control. In a recent study from our group with lupus patients, premenopausal women, after 1 year of follow-up, bone loss was associated with cumulative and daily glucocorticoid use, and interestingly, lower P1NP serum levels, a marker of bone formation at baseline, was a predictive factor for bone loss. So, lupus patients present a lot of risk factors for osteoporosis and fractures. Supporting this notion, the prevalence is higher for osteopenia and osteoporosis in lupus patients, among up to 74% for osteopenia and 68% for osteoporosis. This range variation could be due to study design, age, ethnicity, sex, disease severity, and medication use. Concerning symptomatic fractures, it has been described in the literature to the frequency to 6 to 12.5%, and the most sites frequently involved are vertebral, femur, rib, foot, ankle, and arm. In a population-based cohort with more than 700 lupus patients, the fractures was 5 times more compared to healthy women with similar age. In another study from a Swiss population, the risk for major fracture was higher, almost 3. Concerning symptomatic vertebral fractures, the risk is greater than 2. But this prevalence is higher, since 70% of vertebral fractures are asymptomatic. So, to study vertebral fractures, you have to use X-ray and densitometry, the software VFA. Using the vertebral fracture assessment by densitometry, we observed that the frequency of juvenile systemic lupus vertebral fracture was 13.5%. And in this population, a high frequency was observed in patients with low BMD compared with normal BMD, 25% versus 6%. Also, you have been analyzing bone microarchitecture using high-resolution peripheral quantitative CT. With this equipment, you can measure the peripheral tibial distal and radial distal. Also, you can analyze the volumetric density, including trabecular and cortical density, and also the structure, bone volume to total volume, trabecular number, thickness, trabecular thickness, trabecular separation, and cortical thickness. Studying the left distal radius in juvenile systemic lupus patients, we observed that patients with low BMD present an important compromise of trabecular density and also the trabecular structure compared with patients with normal BMD. No difference was observed regarding the densital, the cortical density, and the cortical thickness. Also, studying the left tibia, we observed that a compromise of the density in patients with low BMD compared with normal BMD. So we conclude that using this methodology, it's easier to understand the compromise of bone of these patients. And finally, the clinical recommendation. It's important to use the to assess the bone mineral density and the vertebral fractures by X-ray or VFA by DEXA at baseline and the follow-up annually, or each 6 months if the patients are beginning to using glucocorticoid. Regarding to osteoporosis fracture prevention and treatment, it is important to prescribe a diet rich calcium or calcium supplementation and also vitamin D supplementation. The bisphosphonates can be indicated if the patients are using glucocorticoid, mainly postmenopausal women and men. The patients present fractures, the patients present osteoporosis by DEXA, and the patients present a lot of risk factors. Regarding to vitamin D supplementation, there is 2 papers in the literature that use supplementation in lupus patients. The first one analyzed almost 300 lupus patients, and the author prescribed oral cholecalciferol, D3, in a dose of 2,000 units per day, and this dose was well tolerated. In another study, analyzed 20 lupus patients with mild or moderate disease activity and with vitamin D lower than 30 nanograms per ml. The cholecalciferol the dose of cholecalciferol was 100,000 units per week for 4 weeks, and after 100,000 units per month for 6 months. And the authors did not observe the adverse events. What the experts recommend? In lupus patients, vitamin D level has to be higher than 30 nanograms per ml, and the vitamin D supplementation could be with cholecalciferol D3 in a dose of 50,000 units per week for 3 months if the levels were lower than 30 nanograms per ml. And after, we could maintain with 800 to 1,000 units per day. So, in conclusion, low vitamin D and osteoporosis are frequent in lupus patients, and therefore is important to screen for these abnormalities. And preventive measures and treatment has to be introduced in these patients. Also, further studies are necessary to confirm the optimal vitamin D doses and the efficacy and safety of osteoporosis treatment. Thank you very much. Gracias.
Now we are open for questions. Not a lot. We don't have a lot of time, but at least 1 or 2 questions.
Luisa Bolton. Can you comment on calcium supplementation on diet and tablets, the advantage of these two, please?
Yes, it's a good observation. Normally, you recommend to use calcium on diet in a dose of 1,000 milligrams per day. You think that is better than the calcium supplementation, since the calcium supplementation, there is a controversy in the literature to increase the cardiovascular compromise. So you only prescribe calcium supplementation if the patients don't want to eat on a diet calcium.
Y nos arreglamos con el portuñol.
Somebody raised the hand over there? No. Okay. I might have a question. You have mentioned that low vitamin D levels are related to certain manifestations like neuropsychiatric and others, but also the medications we use are related to low vitamin D levels. Isn't it possible that the clinical associations that we have seen with certain manifestations are related to higher medication, like high doses of glucocorticoids and maybe anticonvulsivant medication for neuropatients, and it's not a real association with the clinical syndrome, but with the treatment?
Yes. Of course, that the medication could be involved in decrease of vitamin D levels, but there is some papers in the literature that they show that patients in the beginning of the diagnosis of lupus, they already have low vitamin D levels, and in these patients they are not using any medication. So it's probably there is both situations are responsible for low vitamin D levels.
What should be the better treatment in young people if we are talking about osteoporosis or osteopenia?
Normally, for all patients, we prescribe calcium in a diet and vitamin D supplementation. And normally, you measure the concentration of vitamin D, and if the levels are lower than 30 nanograms, you do a higher supplementation, like 50,000 units per week. And regarding to use the biphosphonate in children or young women, normally you only use it if they have fractures or if they have a decrease of bone mineral density during the follow-up. If it is necessary, you usually recommend the anticonceptional in these patients. And if the patients want to be pregnant, we stopped the medication more or less 6 months before the pregnancy.
And with the other treatments that now are commercial, do you have experience in young people?
Yes, like teriparatide, you could use in patients. Remember that teriparatide you only can use for 2 years, but if they have fractures, is a good option because patients with using glucocorticoid was the ones that has more fractures, and the teriparatide, the mechanism of teriparatide is increase bone the actions is in osteoblast cells, so it's better. So you use. I don't have any experience with denosumab, but I think you could use it.
Anyone has experience with denosumab in young people in lupus? No, we don't. So if we don't have more questions, thank you, Rosa.
Okay,
you are
thank
wonderful.
you.